Welcome and thank you for joining this program, Predictable Tissue Management. My name is Dr. Lori Trost and I will be presenting this program today. Just a little about me. I practice restorative and preventive dentistry just outside St. Louis, Missouri and Columbia, Illinois. Above all, I profess to be a lifelong learner, and I'd like to take this opportunity to thank those responsible for this program, Premier Dental Products, and the Viva Learning platform. I would also like to disclose that although I have no personal financial interest in any of these products, I am receiving an honorarium for this program. All the procedures and products used in this program are supported by the literature and used in my practice. If you have any questions during the program, please go ahead and type them in the questions box below, and I will answer them at the conclusion of the program. With that said, I consider this a privilege to share time with you and show you some of the clinical and practical opportunities that we all get to experience every day. Here's the clinical truth. Managing gingival tissue is really a big challenge. I can't tell you how many times I thought the retraction cord was perfectly tucked into the sulcus and the tissue looks stable, only to pull the cord out, discover a little bit of bleeding starts, and it won't stop from aggressive rinsing, and then this all begins to detour or derail the impression process from proceeding. The frustration from tissue that does not properly retract, continues to ooze or bleed, causes a lot of unwanted interruptions and less than stellar outcomes. Even straightforward cases like you see here, even traditional cases that walk into the practice that the patient has healthy gingival tissue, it can still have problems, and we need to really pay attention to how we go ahead and work with patients keeping their oral hygiene in good check, because it only helps us in the long term. Straightforward cases, even like with bonding or fabricated and temporary, can also be affected by very unpredictable tissue as well. Great restorations start with solid restorative principles, and teeth that are properly restored and respectfully prepared need distinct margins that are isolated and the capture of the adjacent embrasure and includes representation that is made into a well-defined impression so the lab has something excellent to work with. What about multiple preps? It just notches up the difficulty and the challenge. It's hard enough to capture one tooth, let alone one prep at a time, but now you multiply that and multiple preps. Tissue management is really, really tough, very frustrating, can be very chaotic, and can really cause just a lot of change in our schedule daily. It can cause change within the patient's schedule. So we really need to learn how to grab concepts and ideas that we can adopt to really make it better and easier for all of us involved. Speaking of crowns, they account for about 48% of our total practice production and are the largest billable procedure in our offices today. The average office in the United States performs about 256 single unit crowns in a year, and if you translate that, it comes down to about 21 crowns a month. You know, that's a lot of procedures that need a lot of tissue management for impressions, and it's very clear that we need to adopt consistent approaches to exposing margins and controlling the tissue. Whether the impression is made with a conventional impression like you see here, and all of us are still doing this very, very much and very, very often, but our profession is changing now and going into the digital world, and digital impressions demand, again, more finesse and more accuracy. And I tell you right now, working with digital impressions, I love doing that, but you again have to have really, really clear and distinct clean margins and clean impressions and well-managed tissue to make that work properly. The rationale for and the methodology of tissue management is critical in any aspect, especially for the digital preparations like you're seeing here. And all tooth preparations must be captured in a circumferential manner in which to have that new crown or crowns fabricated. Today, this program is going to discuss current tissue management options. And we're going to talk about tissue biotypes and the role they play in marginal isolation choices. We're also going to talk about how and why margins are often inadequate. And finally, I'd like to introduce tips to help make impression making more consistent. You know, it's interesting with impressions, it's not just about how the impression is prepared, but it's also the capture. So I really want to focus on some tips and tricks that I've learned throughout my experience in clinical expertise that I've learned that I can share that really help make things simpler and more practical for you to take away. I would urge all of you to visit your lab technician and see why they are sometimes frustrated with what's sent to them. It's really good to see the restorations, how they're fabricated, but more importantly, it's really important to see what's sent to the lab in order to see what needs to have a final quality restoration. A lot of times what they're given is really, really difficult to work with. So I really encourage you to have a very excellent relationship with your lab and really make sure that you have a one-on-one communication with them so that they can help you become a better clinician as well, because you are a team and you're a partner. And I think moving forward, we all need to do that. It's interesting, there was a survey in November of 2015 here that with Lab Management Today, and they stated that 47% of labs list impression quality as the top challenge they have with clinicians. And I think as a profession, we are better than that. So I would encourage all of you to really notch up your game, work, communicate, and partner with your lab better and more to understand how to become better and to be able to provide them the right necessary tools to make exceptional restorations for you. Diving in a little bit more into the science here, here's an article that showed about 89% of impressions had one or more observable errors and when they were sent to the lab. And I want to really point out a couple things here that add up to this math here. Bottom line, if you look here at voids, you're looking at 50% here. If you look at, again, the lines of the air bubbles and finish line here, I'm going to go ahead and mark this as well. Here's another 40% here. And if you go down to where retraction cord attached to the impression, also, if you tally those up, these are all very controllable concepts and methods that we can go after, that we can really finesse and be better as clinicians. Considering that almost 90% of the impressions had an observable error, let's look at it more in depth and dive into this a little bit more. Voids or tears of the finish line. What causes that? Again, this is somewhat related to tissue management. It also could be related to how the cord was perhaps dispensed. Maybe there was contamination at that time. Maybe there's bubbles at the finish line. You've got to realize what necessarily is there. Was there residue? What kind of surface are you trying to capture? How clean and clear is it? We could also look at syringing techniques, viscosity and impression materials, but often we can't put the blame on the material. It's really our technique. A lot of times, too, there's also working time violations. So, again, there's different reasons why there are errors. We need to dive into this, understand it better, and really bring it back to our practices to understand what we can do better and how we can do it better. So I want to ask, how do we prevent curvicular oozing? Do you have a reliable method that you use to manage tissues? Do you have something that's completely consistent that you can rely on time and time again? Are you wanting to learn and look into other methods or materials that can help you better expose your margins? I'm going to put out there that this program is not about shortcuts or quick results, but rather about doing procedures with intention and discovery. We must also look at what's failing before we really can fix it. You know, Ben Franklin said, by failing to prepare, you are preparing to fail. And I think this so much applies with tissue management. If we go into a situation that we know is failing, we need to back up a little bit and prepare more and better. So this is really a course that's going to talk a lot about that. Ultimately, tissue management is about deflecting the tissue enough to allow for the margin to be exposed and the impression to capture that area. Tissue management also involves effective hemostasis. But what you need to understand is it needs to have the goal that it does not do any damage whatsoever to the epithelial attachment, and it also should not yield any systemic effect. I want to start off by reviewing the sulcus. This is a shallow crevice or space that circumferentially borders the tooth and structure on one side, and on the other side is the epithelial lining of the free margin of the gingiva. In healthy tissue, this space is traditionally about 2 millimeters deep and must be treated with respect and a lot of caution. Any disruption or detachment of the tissue from the tooth by either mechanical or chemical means could potentially cause tissue injury, which could result in permanent tissue recession. Clinically, this could result in a deeper periodontal pocket or perhaps even an exposed margin. And I know I've had this happen to me before. I know that I've violated this, but again, learning from mistakes, moving on, that's why we call it practice. You get better. So you've got to understand that concept initially. Margin placement is another critical aspect, not only just for aesthetics, but also for the long-term cleansability of the restoration you're going to provide. Given a virgin surface, supra or equigingival marginal placement is ideal to periodontal health and aesthetics, of course. However, more often the case, when you are clinically replacing a crown, the margin placement may already be dictated, and therefore you have to really work with what you're given. So again, knowing the cellular depth, taking a periodontal probe, probing the depth around the tooth, making sure that you have the proper biological width. You know the depth of the sulcus, you know the depth of what you're doing. Also, you're assessing the tissue when you're starting to do this initially as well. It's really a great idea to do this before you even start to prep, so you have a good assessment straight up of what is presenting right then and there. For existing crowns, like I talked about, make sure you probe periodontally and understand that you need to make sure if there's a subgingival marginal placement, it's going to be difficult at best, and it does carry the most risk. So you might have to back up, and if you have a deep margin and it might involve too deep of a pocket, the cleansability issue, you might have to go back in and talk with your periodontist and work with that and sculpt that bone in that pocket area and get that into a much healthier relationship. Current methods of tissue management and retraction fall into two categories, mechanical or chemical. I do want to say at the outset, this particular program will not really review the mechanical means of using a laser or electrosurgery. Other than that, we're going to focus mainly on retraction cord, compression caps, and of course the chemical means by which you use paste or hemostatic agents. Among the different techniques proposed in the literature, the retraction cord procedure as well as chemical means seems to be less traumatic than electrosurgery or gingival curettage, and it does lower the risk of gingival recession caused by the impression. Retraction cord comes in many varieties and sizes. You can also use retraction cord in combination with another cord, retraction paste, and compression. And here you can just see a couple samples here of what this can look like. I want to dive in a little bit about different sizes, whether something should be impregnated or plain or not. And again, a rule of thumb is you should have a 4 to 5 minute placement on a total placement. So if you're using a double cord, and we'll go into this in just a little bit, total time of 4 to 5 minutes. After that, you start to lose some predictability, and more importantly, you start to lose the effectiveness of what you're placing, and that's more the issue. I want to talk a little bit about the designs of the retraction cord. Most retraction cords are composed of cotton. They're twisted, and some have, in the case of the twisted, have about 2 or 3 strands that are twisted tightly, and they're made, again, out of the cotton. Initially, they present very, very tight, but twisted retraction cords do unravel easily when they're placed, and they really lose their intended function pretty quickly. Braided cords have a tighter and more consistent weave, as you can see here. For many clinicians, they are easier to place in the sulcus with either a serrated or non-serrated packing instrument. Knitted cords tend to unravel less when they are cut, and due to their interlocking design, they are theoretically easier to place. Since they expand when they're wet, knitted cords will open the sulcus greater than the original diameter of the cord. So personally, they're my go-to type of cord, and you're going to see some of that coming up here in some cases. Whether twisted, braided, knitted, or whatever cord selection you're choosing, and the variety of diameters or sizes, ultimately it's a personal preference, and I think you need to learn what works within your hands, what works best clinically with you, perhaps with your assistant, and how you dispense this, how you have your system down when you're measuring, when you're placing, how you're rinsing, all of that. And we'll talk a little bit about details in just a bit here on that. I do want to bring out how dispensing is very, very critically important here, and sometimes this can start the whole process and derail it. Retraction cord is dispensed now in spools. Some containers provide already a cutter, like within the lid, and yet others are actually produced kind of like as a single unit package right now. The important thing to remember when dispensing, cutting, or placing any kind of retraction cord is to use latex-free gloves. Latex contaminants can have a detrimental effect on the setting of polyvinyl impression material. This is really important, obviously, because when you take light-bodied impression material first into the sulcus, it will be interrupted. It will not be allowed to cure completely, and as a result, you get inaccuracies and tearing of the fine gingival margins. So go back to that initial article that I showed where there's problems with and around the margin. This could be an indicator that something's happening when your retraction cord is being dispensed, that latex touched it. So it's really, really imperative to have whoever's dispensing, cutting, and placing the retraction cord, that they need to wear nitrile or latex-free gloves. Super important. Here are some examples of retraction cord packing instruments. Many clinicians have their preferences. Personally, I find that I use either ones here that you see. Those are my favorites right now. I can tell you the design of the instrument is limited to the manufacturer, but many dentists really do use two. And due to the design or the angulation, how it kind of fits or tucks in around the preparation, we kind of learn quickly what works well in our hands. And again, you want to use something that allows you to put gentle pressure. It minimizes the trauma, and that's really, really critical to bring forward here, because you don't want to push too hard. Again, think about that, those epithelial attachments. You don't want to disturb any of that whatsoever. So again, preferences, some are serrated, some are more rounded, some are thinner. So again, look what's out there in the market. Look what when working, talk to your friends, your colleagues, your study club, and they can guide you into different means by which different tools and instruments work well. Regardless, the end of the cord packer needs to be thin enough, especially to place around the gingival sulcus without damaging any tissue, and obviously without causing any bleeding, because you don't want to set yourself up starting with bleeding initially when you're packing the cord. So again, gentleness and tissue deflection have to marry together right there. I can tell you right now, again, like I said, I use both of these. I like the slide packer from Ultradent. I think that works very well in my hands. And Norden has a nice thin curved tool. I also use this for the anterior region predominantly. So it can tuck these different retraction cords carefully, and it can just kind of walk that around, and it works extraordinarily well for me. I want to talk a little bit about different methods in which to pack retraction cord. There are two methods. One is a single cord technique. The other is a double cord technique placement. The selection of the cord is based on the depth of the sulcus and the soft tissue type, and we're going to go into a little bit about that in just a bit. You also need to remember that once the cord is pulled from the sulcus, you have approximately 30 seconds in which the tissue will begin to restore to its original position. So if you're using a single cord technique, you need to see, as this is illustrated, you might be setting yourself up for a poor result, mainly because once that single cord is pulled, the tissue will start to, again, reposition itself, and you really don't get an adequate coverage of the margin. The goal here is, again, to expose not only just the margin, but the tissue below, so that way you have a very proper emergence profile that the lab can recreate for you. Another technique is the double cord technique. And what you're doing here is you're going to take the initial placement of a smaller cord, such as a 000 or a 00 that will be followed then slightly by a larger cord after that, maybe a 0 size. The first cord is acting to seal basically the base of the sulcus. And you can see here it drops below the margin. The second cord then acts to deflect the tissue laterally. Therefore, you can get a better emergence profile of just the margin as well as the emergence profile below, so that the deflection of tissue really helps you capture that. And especially for the lab, that's really critically important, and for the periodontal health for your patient down the road. A few things to note: when you're placing the first cord, you need to wet it slightly. And that could be either with water, or if you're using a astringent or some type of type of Hemodent or whatever kind of product you're using, astringent. When you're doing that, you wet it slightly, and you want to kind of twist it, and that'll help you place that first cord a little bit easier. Again, you have about a 30-second window once that top cord is pulled out. What you do need to remember is also with the double cord technique, because you're placing an initial cord, a smaller cord first, that 5-minute timing, 4-minute timing starts then. And then by the time you're placing the second cord, you have maybe about a 2-minute placement that has a chance to work and to do its effectiveness of laterally positioning that tissue. I'd like to review a few common gingival presentations that we see clinically and kind of get an idea about how I go about assessing what kind of cord I'm going to need and what I'm going to use, why I'm going to use it, etc. And it's always great to start off with normal gingival tissue. Here, this is an easy case. You can say, hey, I can do a double cord. I can place a 0 initially, and because this is an upper molar, sometimes it can be a little bit more fibrous, so I would follow that up with the second cord being a size probably 1. And I'd allow that again to stay in their maximum time of 4 to 5 minutes. You're going to remove the top cord only, and you only will see the top cord as well. Okay, and you can either use a serrated or non-serrated packer. This tissue is, the beautiful thing about really healthy tissue, and this is a little bit, I would say, a tad bit thick tissue. I don't want to say the word fibrous, but thick because of the molar preparation and presentation. You can get away with either serrated or non-serrated packer. Again, with any kind of hemostatic agent, you need to make sure that if that's on your initial cord, that you leave that in there for a 5-minute placement, because that will allow that material, that astringent on that chemical retraction, to allow that to work within that cord for that time allotment as well. Always respect fragile tissue, and I think we have cases where we have patients who come in who have scalloped high or thin tissue. Often this is in the anterior area. Sometimes it can be in the premolar, maxillary premolar area as well, and we have to be very, very careful how we place and what we select. So again, I would go to a non-serrated packer for this because I don't want to have any chance to damage that epithelial attachment there. I want to make sure that whatever I'm sliding in there, it's going to be smooth and very thin. And again, the cord sizes are all going to be very, very small. Again, I want to also bring out the idea that you have to be very careful with a lot of the hemostatic agents that are out there, because they can provide staining for about 24 hours, and you really need to make sure you inform your patient that could happen. So be careful of that. Another warning I want to make is epinephrine can often cause local necrosis. So one of the things you want to be careful of and be aware of is taking just basic, any kind of some of the epinephrine combinations that are out there, and literally just soaking the cord and placing that, because that could cause tissue necrosis. So again, that would be counterproductive for what you're really trying to do. On thick or fibrous tissue, you always want to use a double cord, because obviously you've got to retract and laterally position that tissue, and it's very, again, thick, and it has the ability, it can be very tough. Again, you can use a serrated or non-serrated packer. Again, the smaller size initially was maybe a 0, 0, or a 0, and then go up to maybe a size 1 up to a size 3. And a lot of times you'll see on first or second mandibular molars that this will present itself. Again, on a maxillary second molar, that tissue again dictates the type of cord, the size of the cord, as well as the packer that you're going to select. Anytime you introduce chemicals into the equation, there's a balance that you need to achieve. And these elements manage tissue by causing a contraction-retraction, and the hemostatic agents constrict blood flow through coagulation. These agents will initially cause a transient ischemia, shrinkage of the gingival tissue. We do know that chemically impregnated cords are better and offer better sulcus displacement, as you both have mechanical as well as a chemical effect. Various compounds on the market today include aluminum potassium sulfate, aluminum sulfate, aluminum chloride, and different variations and percentages. Ferric sulfate is another one, and racemic epinephrine. Racemic epinephrine impregnated cords can cause elevated heart rate and blood pressure, especially if placed into bleeding tissue. The literature shows there's no clinical benefit in gingival retraction with this. But if you still choose to use them, be careful and drop down to a 4% solution that you're going to use. It's safer for cardiac patients than what an 8% solution would be. The consensus seems to be that using pre-soaked cords is more convenient than cutting, soaking, and blotting before placement. Here's a sample of some of the current hemostatic agents on the market today. These liquids may be dispensed using a syringe, or others require you to soak them in a sterile, dampened dish. Clinically, these agents can often cause coagulants to accumulate in the sulcus, and they can be difficult to rinse. So again, these are options that are out there. Again, some of these materials now have impregnation within the cord itself. So whatever, again, works in your hands, and you can see clinically what is the best choice that can provide you the tissue management option as far as hemostasis as well as the tissue deflection. I think that has to be your choice. Ultimately, you've got to be kind to that tissue. You want the patient to be happy and you want the patient to be comfortable. So we have different combinations that are out there today, and I think you can find those combinations with what is available. Retraction pastes are another means chemically by which you can provide hemostasis along with moisture control, and they can be used in combination with other retraction methods such as cord or compression. You can see here a couple of the ones that are out in the market today. These are terrific because they're easy to use and place. They have, I think, a lot of function within dental practices today. They absorb crevicular fluid. Most of them are based with an aluminum chloride or aluminum sulfate type compounds, and a key element here is they have no tissue discoloration that they yield. So that is a nice benefit. You don't have to explain to a patient that they might have staining for a little bit with using some of the other products that are in the market. So these to me are a great winner to use in the practice. They're also terrific for other clinical presentations that we have, things like composite placement, cementation, and even temporization. So I use these all the time. They work very well. They're predictable. They're easy to place, easy to use, easy to rinse off. And you're going to see that in a little bit because I use them on some clinical cases here, and I think you'll see how nice they can work. And finally, retraction caps apply pressure or compression by using cotton that is designed to mimic the anatomic gingival form. And again, there's various ones out in the market today. Most of these are all made out of cotton. They help not only with the absorption area, but they help with a little bit of hemostasis. But what I find too is they're very comfortable for patients because, you know, after a longer procedure, it's comfortable for the patient to be able to bite down and kind of squeeze into that cotton compression cap. So I like these, and we do use these a lot. I think patients appreciate being able to close onto something, and again, it doesn't allow them to interrupt what's being placed there too, either via, say, perhaps retraction cord or even any of the paste or any of the other hemostatic agents that you're using. Let's go into some clinical cases now and see what's possible and different combinations of things and how things present, and kind of walk through why and the hows, okay? This case demonstrates a margin that's both equigingival and supergingival. And again, I like to talk about different tissue types, and I'll be able to share a few of these here. This is a biotype that has a normal presentation. The tissue is, I would say, normal to fibrous. Again, you got a lower molar presentation. Some of the tissue is going to be a little more fibrous on the lingual aspect on this. It's going to be a little more normal, wrapping around the mesial area to the buccal. The distal can be a little soft or spongy there. So again, there's some slight bleeding here, and that's where that margin starts to dip down a little bit, and I got to be careful that I'm able to really manage this properly. So I'm going to use a double cord technique. I'm going to place a 0-0 cord. I'm going to go ahead and wet it with water initially. I'm going to go ahead and place it and slide it down around the preparation in a circumferential, kind of loop it over the tooth. And the second cord that I'm going to use is going to be a size 2, and going to move forward from there. You always need to evaluate that gingival health initially, and also the depth of the sulcus. You need to select a diameter that's going to look like it's going to fit, and that's really critical as well. Here I'm going to use that slide packer here from Ultradent. You can see here I'm going to tuck this, and I'm just going to kind of fold this backwards in the sulcus. This is the second cord you're seeing here. And you want to measure these again to this so there's no overlap. These completely wrap around the two circumferentially, and they're not overlapping. You don't want to have any kind of tails. If they don't overlap, they're going to expand and they're going to be able to stay in place easier and better. Sometimes certain cord selections will unravel or they will unwind, and they don't have the ability to stay effective that way. So again, this, I think if you find knitted cords, they work much better and easier. The smaller cord's going to control that bleeding at the base of the sulcus, and the cord's going to work mechanically with an astringent you can place on top of this, and that function will work nicely too with the lateral positioning as well of the tissue with the second cord here. Right before making the impression, the cord should be wetted with water when you're going to go ahead and you've allowed it to stay in place for the 4 to 5 minutes as we talked about earlier. Again, we wet and we'll rinse it nicely. We don't aggressively rinse it, but we'll rinse it nicely, and that will allow then the cord, once it's moist, the removal is much easier, and it doesn't have a tendency to grab or tear the tissues that could cause or create a little more bleeding. So kind of incorporate that into your protocol, and I think you'll find that works really nicely. When things get too dry, they do tend to tear or grab onto the tissue, and you can really promote a little more bleeding than you'd like to see. Twist the first cord very tightly, like I talked about earlier, and go ahead and gently tuck that along, and then you follow that again with the second cord, like we talked about. And we do this all the time. This is exactly what we do. Walk it in there, and again, fold it backwards into the sulcus, and I just kind of gently, again, I work backwards when I fold it in to the sulcus. Here you see this is going to stay in for about a 3 to 5 minute placement. In this case, I think we're right around 4 minutes where we place this at. And you can see the top of the second cord only here, and you can see how nicely that margin is already exposed. You've got a nice lateral tissue position now already, and the tissue's not damaged. You can see here the kindness that this has been done. We've been able to really elevate that, and we should be able to get a nice impression from that kind of look. You always see the second cord. I just really want to emphasize that as well. So important. Again, I can have the patient close down on a retraction cap, and I think that works very well, and proceed on with the impression. The second case here I want to talk about is really critical, because I think one of the best ways to manage tissue is to adopt a systematic approach to preparing a tooth. Each crown preparation you do, you should have a checklist that you move through. And I think by doing so, you have the ability to really hone your technique and refine every aspect of what you're doing. So I'm going to kind of walk you through a little bit how I'm doing this and why, because I think the more you hone this, the less chance you have of accidentally touching or nicking or gouging the tissue, and that's again counterproductive. So to me, if you have a checklist, you systematically prepare every tooth the same way, you really get a feel and you really get an ability to work clinically in a more predictable manner, and I think it becomes obviously a lot more joyful because you're cutting down your chaos. And I think the more repetitive we can be, the better clinicians we can be. So first off, reduce the occlusion by placing depth grooves. Depending on the amount of space required for the restoration, or the amount of existing space that might be, you need to select a burr that offers the depth and utilize it to not only remove the tooth structure, but I also use it as a measuring gauge for the yet-to-be fabricated restoration. In this case, for single crowns, I like to use a coarse, it's a Solo Diamond by Premier. It's a single-use, cost-effective burr, has excellent cutting ability and efficiency. And basically, it's a one-and-done type burr, so it has a flat end on it. Again, it's coarse, and I'm able to literally create depth grooves. I connect the depth grooves. I'm ready to verify my space, and now I can move on. Next, I want to break the interproximal contact, and here I'm going to be using a flame-shaped burr. You can see how these are all listed. And also, by the way, at the end of the program, I'll share my email address. If you're interested in getting a materials list of everything I'm using here, I'd be more than happy to share that with you. Another trick that I found, I often will place a wedge guard to protect the adjacent tooth structure. This is especially nice for pre-existing gold crowns, which I know that are easy to nick, or even any kind of ceramic restoratives. There's nothing worse than having to go back and try to smooth or polish an adjacent surface that's been nicked. So again, save yourself the time and the hassle. Place a wedge guard in there, and you can prepare against that and open up at interproximal contact, and then your burr goes against that wedge guard versus the tooth. That's seriously important, and I think that really helps a lot too, and these are easy to work with too. Another trick I've learned, sometimes when you're breaking the interproximal contact, you can take actually a 0,0 size cord, and you can go down and go ahead and place that initially, and that will also help your tissue and protect it just a little bit too as you're breaking the interproximal contact. So again, those are just little tips and tricks. Everything is different and presents individually, clinically, and I know that, but again, more things you can have and tools in your kit, the better off you can be. Next, I like to use a football to reduce the buccal and lingual aspects of the tooth. This also helps me to start sight where the margin is going to be placed at. And when I'm working with this, I want to keep in mind that all the line angles I'm going to work with are going to be rounded, and especially that's very important for ceramic performance. Then I'm going to go ahead and start to finalize my margins. When the final taper and the line angles have been completed, I finalize the margins. And I found that by moving in a counterclockwise circumferential rotation, I can create a nice and better margin with more control. And I've really worked with this over time. So again, a counterclockwise circumferential. I don't sit there and just go back and forth, and literally slowly move around the tooth. I work in a full circle counterclockwise, and as the rotation of the burr is, I'm going against that, I feel that I can hold the burr into the tooth better and create a softer and kinder and easier, gentler, better margin, and that has worked very well in my hands. Again, it helps me make sure I don't damage the tissue. Again, it's all about control. I'm relying also on my burr and whatever my specific choice is of my burr. I'm relying on the depth and the width to be a gauge for me and a guide for me too. So again, choose your burrs to help measure, but also help to reduce the tooth as well. And of course, you want to make sure that whatever burr you're selecting for your margin is proper for the ceramic that you're going to have the lab prepare for you. This case is an example of an equigingival height marginal placement. You can see here the tooth was prepared for a zirconia full crown. I like to polish all of my restorations as well with either a fine diamond or even composite polishers that you see here, these enhanced by Dentsply. Once the preparation is polished, then I like to go ahead and take a microbrush or even just a cotton pellet that's been soaked in chlorhexidine, or even you can use hydrogen peroxide. And I like to go ahead and I just like to really scrub the tooth and around the tissues and just get any residual or remaining tooth dust or whatever's on there off of there. And I think it's very kind to the tissue. It helps keep things clean. And I think the cleaner we can make our preparations, the better for the impression, regardless if it's a traditional impression or a scan. And this really also starts to set the stage for me to get a better insight about what kind of tissue response that's presenting at this very moment, and more importantly, it helps me make a right choice for what kind of tissue management options I need to employ to get a good impression. In this case here, because where the margin placement was, I was able to use a retraction paste, and Traxton is one of my very favorites. I really like this product. I didn't need to use cord because the margin of where it was placed at as well. I just wanted to make sure that I can maintain the tissue. So I chose a chemical means here. I syringed Traxident around the margin. It's a very absorbent paste, and I can go ahead and marry this with a retraction cap and get a very excellent impression. This is so kind and so easy to use. It has a 2-minute placement, and probably to me one of the best things is it's easy to rinse off, and once it's rinsed off, you can feel pretty confident that you're going to have a very nice controlled environment in which to take your impression. On top of that Traxident, I'm going to immediately place that retraction cap. There's different sizes that are out there. Again, work with these. Some of these you might sometimes have to customize and just take scissors and lightly trim them. However, whatever presentation comes to you clinically, know that you can do that. You just got to work with that, make that happen. And once the patient's going to bite down on this, I'll leave it undisturbed for about 2 minutes, and we'll be ready to take the final impression. Then we'll rinse that off. And I really like this. You don't have to worry about any other astringents. I know that I can really depend on this type of combination to have a very, very clean and nice preparation in which to capture with an impression. Here you can see the final impression. This is the immediate removal of that exact case that you just saw there. And I want you to notate truly how clear and how clean and how well exposed that margin is and how easy that is to read. So this wasn't rinsed off. This is completely out of that patient's mouth. You don't see blood. You don't see oozing. You see clean. And I think that is so very, very important. Again, I think working with that chlorhexidine and the peroxide to really cleanse the prep at the very end, keeping the tooth and the preparation moist is ideal, and then moving into the impression to capture it, working with a retraction paste like you just saw here and a compression cap. I think those are just winning combinations. Here's a case that has a normal tissue biotype. There's slight bleeding with a partial subgingival margin. And in this case, I'm going to use a combination of retraction cord and paste to achieve impression readiness. And I'd like to emphasize again that when you're managing tissue, there's no one size fits all. That would be great if that could happen. It's just not the case here. But you can see again what I'm assessing, the biotype, where's my margin, I need 1 cord or 2 cords. And in the case of with Traxident here, the nice thing about the double cord technique with Traxident, I can place a cord and then I can go ahead and I can use Traxident as the second cord. So that's a really nice advantage here, and I often do that. I've selected a knitted retraction cord because it doesn't fray or tear like I talked about earlier. I think knitted really stays in place. It expands slightly. It helps to push the tissue laterally away from the margin. And I'd also like to notate that this particular knit pack retraction cord is not impregnated with any kind of astringent. So I'm going to go ahead and place this initially. Studies show that knitted cords were preferred over braided cords, and there's really no advantage to having cords impregnated with epinephrine. So this cord has no treatment. It's a plain retraction cord, knit pack cord. I'm going to go ahead and place that, and then on top of that, I'm going to go ahead and place my retraction paste. You can see here there's Traxident being placed. I'm going to allow for this to stay in place for 2 minutes. Again, it has the ability to really absorb curricular oozing, and I think that's just so critical. Moisture is an environment that we work in daily, and if we can get that to be controlled, all the better. So this is a nice combination. Whenever I'm going to go ahead and get ready to rinse this off, we'll rinse this off and then go ahead and pull the cord, and we'll be able to have a nice, I think, comfortable experience for the patient too. And I think patients do know the difference. They really appreciate their tissues not being, I should say, interrupted, but altered or uncomfortable. They know that they've had a good experience when they walk away, and their anesthetic wears off. They're just happier with that whole experience. And I think this is a really great combination. You can see here the immediate preparation after the impression was removed. And the reason I'm showing this is, again, to show you how nice, clean, and well respected the tissue was after the procedure. So again, that makes a great combination, I think, for the patient. I want to emphasize again too, when you're doing this, when you're removing that cord, wet it first, rinse it, wet it, get it wet so that way it doesn't have a chance to grab the tissue. Then you can start to air dry your preparations and set the stage for taking that impression. Again, you've got that 30-second window in which to start syringing your impression material around that preparation before that cord has a chance to fall in or the tissue repositions itself. You need to really be prepared to syringe, and that's a real critical element in timing. And the other thing is there are violations with timing with the impression material. So have your impression synchronization down with your assistant or assistants. Sometimes I bring in another assistant just to be able to help with the syringing and to really keep focus, because this is a really tough, these are tough to do sometimes. So more hands in my world, the better sometimes. If bleeding does persist when the first cord is removed, go ahead and make the impression anyway, knowing it won't be acceptable. Don't even look at it, but then you can go ahead and maintain retraction, because the impression will act as an impression, or rather, the impression will act as retraction. It will also act as a hemostatic agent as well, because it'll help keep things in compressed and astringent type of process. And then once you remove it, with that initial impression, go ahead and take your second impression immediately. You're going to know that you're going to need to do it. Just go ahead and get everything ready to go and take that second impression in case you do have bleeding after the first one. So, or when you're getting ready to take the first one. So just have yourself prepared. Again, the Ben Franklin thing, be prepared. That way you won't fail. The final case here I want to talk about is a conversion of veneers to full coverage crowns. Marginal placement already has kind of somewhat been dictated by this, and you can see here the tissue type here is very fibrous. The patient has really a little bit of moderate bleeding. I wish he would have had better home care. We worked with him. This temporary, you're going to see a little bit how we walk through this, but a couple things I know that I'm going to need to do is make sure I use a non-serrated packer. So I want to use a thin blade to place this, and since I'm working in the anterior region and working around fibrous tissue, it's going to be tough to retract that. So again, I'm going to rely on using a cord and Traxinet and going forward here. So you're going to see here, on this case, I used multiple preps. I use my burr for multiple preps. And my go-to are the two-striper burrs, diamond burrs from Premier. And you can see here their numbers and their styles and their designs. The reason I like to use these is these burrs are the fastest brand in efficiency and effectiveness per a CRA report. And each two-striper diamond is going to be used on 4 teeth here, so I don't have to constantly change burrs or get new burrs. I'm going to use one burr, and it's going to help do four teeth, and then I'm going to use the next burr to help. So reduction, and occlusal reduction, size reduction, interproximal, and each of these have a specific design, so I don't have to use a lot of different burrs. I can use one packet like they're offered in here, and I can rely on their effectiveness and their performance. And I really have shifted to this, and then once these are prepared and used, they're going to be disposed of. So again, I think the cost effectiveness and the cutting effectiveness are really a win-win for my world here. You're going to see here the preps on a down view, and at this point in time, I know that I've got some challenge here. So not only is this going to be a case where we do a combination double cord, where we're going to place the cord, but I'm going to have to really rely on something that helps to keep that oozing and that bleeding at bay. And this is tough. I mean, to take impressions on 4 teeth, it's hard enough to sometimes just doing 1 tooth, but this is a tough case here. And then more importantly, this case involved doing a digital scan, so you really need to sit there and pay attention carefully then how well those margins turned out. So I'm just going to leave this view up of what this margin clarity looked like. And again, I had to rely on Traxinet. Once I had the cords in place, placed the Traxinet, and had the patient just kind of bite down on a 4x4 gauze that covered the anterior region so his tongue could not go into that area that to disrupt anything. And you can see here the marginal clarity. So I was quite happy with that result. And moving forward here, you can see immediately following the digital scan what these preparations look like, and the clarity again. And you're going to see here now the final restorations of how well things were managed, and you can see with the provisionals. Again, Traxinet can be used if we had some kind of bleeding that we needed to keep at bay or any kind of oozing, and then you can see the final restorations on the bottom view there. So again, I have to use reliable things. I want to use reliable, tissue-friendly, and tissue-respective products in our practice, and I think that's so very important here. So I was pleased with that result, and the patient was too. Success does lie in the details, and I think we all know that as clinicians because we're challenged, I know, every day. And hopefully you've been able to discover a few clinical tips and tricks to achieve more predictable tissue management. And I know it's frustrating sometimes, but hang in there, keep at it, introduce little things here and there, talk to your colleagues, take courses, continually read and master, and again, develop that checklist like I talked about earlier, because I think that's so very important to help you really finesse and hone your clinical skills. I think that's really critical. I'm going to go ahead and thank you for joining the program, and what I'd like to do right now is I'd like to say if you would like to contact me, there's my email address. And you can certainly do so, and I will give you a complete materials listing of all the products that I used. And if you want to stay on the queue here after this program completely, you can get educational credit by answering the questions. And with that said, I want to answer some questions because I've got some good questions in here right now that are coming up here. And I want to be able to answer each of these and hopefully get to as many as I can here. So the first question is, sometimes my first cord gets stuck in the impression. Perhaps it wasn't the right biotype for the double cord technique. This is a great question, Emily. What happens is, if the first cord, and the first cord usually can stay in with the impression. The key is to make sure that first cord is small enough that is below the margin, so it helps with the deflection, not only of the tissue, it seals the sulcus, but more importantly, since it's below the margin, it can help with that emergence profile that will be very recognizable when the lab goes ahead and either pours or does a digital scan. So again, if it's in the impression, again, what I'm thinking is you might have too large of a cord, so drop down to a smaller size, see how that works, and then maybe with your the biotype and the tissue, again, these are all individual, and these cases are all different. So you have to know and assess biotypes, sulcus depth, etc. So another thing I've asked you to look at is consider the sulcus depth in which you're working too, and that might be part of the problem as well. Got another great question here. With the two-cord technique, you remove the first cord. Why? Don't you promote bleeding upon removal? Yes, you can promote bleeding upon removal. You got to be careful with that, Scott. So here's what I'd recommend. You want to be able to definitely remove. You keep the first cord in. The initial cord can stay in there. With the second cord, though, rinse it lightly, start to air it, and then, or rather, start to rinse it, remove the cord, and then you can air your preparation for the impression. So hopefully by wetting it, you will not engage or encourage any kind of bleeding upon that removal. And that's kind of a trick that I've learned over time. Got another great comment here and question. I found success with a single cord placement with another layer of retraction paste on top. Again, this mimics the double cord technique, and I'm glad that people are coming up with this, because instead of having to pull the top cord, you just basically are rinsing the paste, and it helps to eliminate the bleeding, and you're allowing that initial cord to be placed and remain in the sulcus, and it keeps things nice and dry, and it helps a wide open sulcus to be captured. So again, that's great stuff. And I'm glad to see that people are really grabbing and grasping onto these, because these are great clinical tools in our kit that we can use here. I've got a couple more questions here. Is there any kind of allergies to Traxident? Not to my knowledge. And again, I would talk to the manufacturer if you have any questions. You can always certainly make a phone call, but to my knowledge, no. These are compounds that are used and been cleared, so I think you're fine there. So don't worry about that. I think it's very safe. And you know, another thing, like we talked about earlier, it doesn't provide any gingival staining. So that's a really, I think, a plus. Easy to rinse off, easy to place. I think in combination with a retraction cord, it's a great win-win type of tissue management system. All right, I think that, let's see here. Okay, got another great question here. Why is there a 5-minute limit with packed cord? Great question. 5 minutes is what the window of time that when you treat a retraction cord, or it has already a chemical element introduced in it, the 5-minute window is the effectiveness window of time. After that 5-minute window, you really lose the effectiveness of what those chemistries can do within that cord, within that sulcus. So 5 minutes is really where you're at. After that, too, you also have the chance of potentially damaging tissue, because you can introduce the chance of necrosis along with other just epithelial disruptions. So 5 minutes is really pretty well the balance of time there. So look at that time frame, set your timers, and make sure you're paying attention to that. I've got another great question here. Can you talk a little bit about how to use Traxident? I've never used it before and was wondering how difficult it is to place. Traxident is a a product that is easy to syringe. I have been using it since it came out as a syringe type dispensing delivery system. They now have a unidose system that you can actually place within a composite delivery dispenser syringe, or gun. So that's a nice way to use it as well. But I can tell you this much: it's easy to squeeze out. You clear the tip, obviously, place it, and it stays nicely placed. It doesn't slump, it doesn't fall off. It's easy to go into the sulcus area around the tooth. The tip is easy to bend, so the access is great, and I've just really found it to be a very, very good adjunct to our clinical procedures, and it's used in so many different variations, like I talked about earlier with composites. Sometimes you might get a bleeding with even just cementing something or adhesive type of cementation, whatever you're doing, however you're doing it, and it really is a go-to great product. Another great question. I find it easier to place the first cord after the depth and the interproximal reductions. And would you recommend doing this? And I absolutely love that idea. I think a cord can certainly be placed after that, after those two steps. I think the reason you can start to get tissue, obviously, you can decide where your margin is going to be, and you can start to understand that tissue management starts to happen then and there. So again, look with your working time. If you know that you can get your preparation done within that window of time, I think you're good to go with that. So I think that's a great way to do that as well. Another good question is, what causes the tattoo or the discoloration or the gingivals around the crowns? When you're doing preparations, often some of the compounds might have some of the different ferric or the iron components and the sulfate components can cause some tissue staining, and that traditionally doesn't last more than 24 hours. So again, it's something that you need to inform your patient on, and if you, I think, can avoid those type of compounds, I think you're better off. I think it works a little bit easier and better for you, and you certainly don't want to interrupt or surprise a patient by not telling them correctly. All right, I think we got most of those questions answered, and I'd just like to say again, thank you very much for your time, and I wish you the best part of your day to come, and have a good rest of the week. Thank you very much.